Now let's have a look at the parotid gland and its innervation and see if there's anything how we can, well, kind of compare and contrast it to the other salivary glands we have. Our parotid gland is right here, so we actually have two. We have one on the left side and one on the right side. The innervation of the parotid gland is different. It actually comes originally, the parasympathetics at least, come from the glossopharyngeal nerve. The other two pairs of glands that we have are going to be the submandibular gland and the sublingual gland. The cranial nerve that is responsible for the innervation of the submandibular and sublingual glands is actually cranial nerve number 7, the facial nerve. And the ganglion for this is called the submandibular ganglion, as you can see here. The submandibular ganglion is hanging off of a branch of the trigeminal nerve called the lingual nerve. And so along the lingual nerve, which is actually from trigeminal, as I said, you have the parasympathetic fibers. They're presynaptic. They then reach the submandibular ganglion synapse here, and then they travel to the submandibular and the sublingual glands. Well, so if you have a parotidectomy, you still have one parotid gland on the other side, unless it's been done bilaterally. That's unlikely. And in addition to that, imagine if you had a lesion in the glossopharyngeal nerve that would lead to the lack of parasympathetic fibers, just in general. Well, you still have parasympathetics come from the facial to the other two glands that you have as a backup. Okay? So, in a nutshell, your secretory fibers to the parotid gland will come from parasympathetic components of cranial nerve number 9, the glossopharyngeal nerve. So, if I now have a look at this picture, why don't we see if we can illustrate that? Here is the glossopharyngeal nerve. The tympanic nerve will contain, here's the tympanic nerve, the visceral efferent fibers that are destined for the otic ganglion, which is over here. The tympanic nerve will actually enter the tympanic cavity through a tiny canal, which is called the tympanic canaliculus. And when it's in the middle ear, so before it continues, it'll contribute to something called the tympanic plexus right here. After the plexus, the tympanic nerve will become the lesser petrosal nerve, briefly, and that leaves the middle ear through its own little hiatus. The fibers will then synapse in the otic ganglion, where they become postsynaptic, and now comes the interesting part. These postsynaptic secretory fibers will then hitch a ride on the auriculotemporal nerve to reach their target organ, the parotid gland. Okay, so if we look over here, let me see if I can minimize the picture. So if you look over here, here's the parotid gland. Okay, there are many nerves that are traversing it. These are actually, most of these are going to be branches of the facial nerve. Here is the auriculotemporal nerve. This is the nerve on which we will have the fibers that are heading to the parotid gland synapse. As the name implies, it is close to the ear, aka auricle, and the temporal region. So that all makes sense. As usual in anatomy, the nomenclature kind of gives away what the big deal is, right? Now I'm going to zoom out here a little bit. All right, let's look at the other side. And if we look all the way up here, we can see there is an opening or a foramen, right, through which the facial nerve comes out, right? The facial nerve comes through the stylomastoid foramen, and then it'll fan out and go through the parotid gland. So you can imagine during a parotidectomy, the surgeon has to be careful not to damage any of the branches of the facial nerve. All right. So when you have a mnemonic for the different branches of the facial nerve, which would be 10 zebras bit my cheek, which basically stands for the distribution region of where the respective nerve fiber is going to. So if you say you have a temporal branch of the facial nerve, I should actually highlight here, there'll be temporal branches of the facial nerve, so 10 zebras would be zygomatic branches, bit are buccal branches, here for instance, my are marginal mandibular branches, and cheek, C as in cheek, would be the cervical branches that innervate the platysma muscle. Okay, all of these branches are important because if you damage the facial nerve, you will lose the muscles that are innervated by it, and in people that have had a parotidectomy, it can take a couple of months for these fibers to grow back. So let's have a look at this diagram again. And the mnemonic, which is going to show up on your screen, is going to be GLOAPS, G-L-O-A-P-S, glossopharyngeal, lesser petrosal, otic ganglion, auriculotemporal nerve, P for parotid gland, and S for spit. So why don't we throw in a few clinical correlations while we're at it. We'll start off with the parotid tumors. Okay, parotid tumors are usually benign and slow growing. It is rare that they grow to the size as you can see here in this individual. There's some potential for them to become malignant, but most of the time that is not the case. So pain or involvement of the facial nerve are signs that it's malignant, and the investigation is best done with an ultrasound scan. Yep. You can see actually here, this is now a CT scan, but already with an ultrasound scan you can see if the parotid gland is abnormally large. Okay, so the pain of a parotid tumor may often be referred as well to the TMJ via the auriculotemporal nerve. So the auriculotemporal nerve is over here, and if you have irritation of the auriculotemporal nerve, as this is primarily a sensory nerve coming from the trigeminal nerve, you can imagine that that is going to refer pain to the temporomandibular joint. In addition to that, this nerve also carries the secretomotor fibers. Okay, so here you see the adult with the parotid tumor. That is a massive tumor here. And here is a CT scan, as you can see where the white arrow is pointing. This is a pretty large parotid tumor as well, prior to surgery, of course. Speaking of the parotid gland, why don't we throw in another clinical correlation, which would be mumps, right? Mumps is a very acute and actually also a very painful viral infection of the parotid and or the submandibular salivary glands. This can affect both children and adults, and you typically actually have several days of fever, headache, and muscle aches, maybe also tiredness and loss of appetite, followed by swollen salivary glands. Here's your parotid gland, there's the parotid duct, here's the submandibular duct, and the submandibular gland, and the sublingual gland and ducts, right? So mumps is really, really painful, and so opening your mouth is going to be severely restricted. You can see here this individual and this one here, they have big swollen cheeks. That must be very, very painful. This is an adult, this is a child here. This must be quite excruciating because the parotid gland also is embedded in a parotid sheath, which is really pretty tough and it doesn't allow for a lot of distension. So you can imagine how much pain that'll cause due to the compression of the surrounding nerves, right? So luckily it is very rare to get mumps nowadays if you live in a country that immunizes their population. Thankfully, mumps is very rare because most countries, or most civilized countries, should I say, they actually vaccinate, and that is part of your MMR vaccination. The mumps, measles, and rubella vaccine, no, it doesn't cause autism. That is a false information, so make sure you always get your vaccines in, all right? If you are not vaccinated against mumps and you contract it as an adult, that is pretty unfortunate because it can actually lead to reduced fertility because you can get inflammation of the gonads as well. Now let's talk briefly about what happens if you have the facial nerve or parts of the facial nerve that suddenly do not work anymore. So in that case you will be talking of a facial nerve palsy, and sometimes people call this, or variants of this, also Bell's palsy. Okay, here's your intracranial portion of the facial nerve. Okay, then very importantly you have the chorda tympani, which is this little branch that comes off of here, and it will join the lingual nerve, which is part of V3, or the trigeminal nerve. The lingual nerve will then go to the tongue, but it is taking with it fibers that have actually come from the facial nerve. And these fibers are going to be taste fibers, but also presynaptic parasympathetic fibers. Okay, the facial nerve comes out of the stylomastoid foramen, so it's a hole between your styloid process and the mastoid process, right? That's where it emerges. And you can see that the branches of the facial nerve go all over the place. Remember, here's a mnemonic: 10 zebras bit my cheek. So 10 zebras bit my cheek stands for temporal zygomatic buccal branches, marginal mandibular branches, most likely these here, and cheek is cervical branches. They mainly go to the platysma. Okay, so the facial nerve will provide motor innervation to the muscles of facial expression. In addition to that, also to the posterior digastric, the stapedius, which is a tiny little muscle in the inner ear, and the stylohyoid, which, as the name implies, goes from the styloid process to the hyoid bone. If we have a lesion to the facial nerve, you will have, or you are likely to have, a decreased salivation. That is, if this involves the chorda tympani or anything in that vicinity, because the parasympathetic fibers will have come via the chorda tympani. These parasympathetic fibers will join the lingual nerve over here, and then dangling off of the lingual nerve is going to be the submandibular ganglion, which I sometimes call a danglion, like a dangling ganglion. I at least find that is funny, and that is where the synapse occurs. So with facial nerve palsy, the lesion of the facial nerve, it might be that you end up looking like this individual here. This person's not trying to make a funny face. He's actually trying to pull up the corners of his mouth and kind of scrunch up his face on both sides at the same time. However, the right side is completely flaccid because he is suffering from unilateral facial nerve palsy. Okay, so remember that the facial nerve does much more than just innervating the muscles of facial expression. So you might also have a loss of taste, or unilateral loss of taste. That means you would actually experience it as a decrease of taste. Decreased salivation because you might denervate the submandibular and sublingual glands. You might also have a decrease in tear secretion because the lacrimal gland is also innervated via branches of the facial nerve. Okay, so this can happen idiopathically as well, so without a known cause, and then it's called Bell's palsy. So that means you suddenly wake up one morning and you have a loss of muscles of facial expression. They're all slack, but over time, gradually, they will return little by little. Other causes potentially for facial nerve paralysis or palsy will include stroke, damage to the facial nerve during surgery, that could be dental procedures or parotid gland surgery or submandibular gland surgery. Okay, so one more time, this person is exhibiting facial nerve or Bell's palsy on the right side. This person is showing Bell's sign. See, he's actually trying to close his eyes, but the right eye does not close, and in addition to that, this is Bell's sign, so he's unable to close this eye, and the eyeball is actually rotated upwards. Okay, so let's try and have a look at the facial nerve one more time here. So here's the facial nerve and the facial canal. You have here facial nerve at the internal acoustic meatus. Right here is the foramen for the greater petrosal nerve. Then you have the greater petrosal nerve that will convey presynaptic parasympathetic fibers, and it will actually merge together with a nerve coming from down here called the deep petrosal nerve. So the deep petrosal nerve and greater petrosal nerve will merge and form a nerve called the Vidian nerve, also known as the nerve of the pterygoid canal. This is important because this nerve of the pterygoid canal will then go to the pterygopalatine ganglion. This is where parasympathetic fibers that have been coming from the facial nerve via the greater petrosal nerve will synapse. And after they have synapsed, they will hitch a ride on a couple of different branches. I'm not going to dive into the details, but it includes branches of the trigeminal nerve and end up going to the lacrimal gland. So, in a nutshell, the facial nerve is necessary to be able to make tears. In addition to that, well, the deep petrosal nerve actually carries sympathetic fibers. These are postganglionic or postsynaptic sympathetic fibers. They have no business in the pterygopalatine ganglion, so they're just going to pass through. But, of course, we will need to have sympathetic fibers reaching the head region as well because of vasomotion, pseudomotion, and pilomotion. So, vasoconstriction, sweating, and your hair standing on end, those are sympathetic functions that have to happen in the head region. Okay. In addition to that, of course, we need to have sympathetic fibers that can travel upwards and even higher and higher up to the orbit, right? Because then actually specifically to the eyeball, because we have some of the muscles that will hold the eyelid open. Yeah? They're actually called little tarsal muscles. And the dilator pupillae, that's the one that opens up the pupil widely when you are wide-eyed, yeah, is a sympathetic response. So we need sympathetics in the head region as well. So let me hide this now. That was the facial nerve. And let's do a little check if the info has been able to seep in so far. Let's review the glands, or some of the glands in the head region. In a nutshell, parotid glands are the largest glands innervated via the glossopharyngeal nerve. Check. Other glands, sublingual, submandibular, and the lacrimal, all innervated ultimately by branches of the facial nerve. Okay? These sublingual and submandibular glands get their innervation after the presynaptic parasympathetic fibers have synapsed in the submandibular ganglion. Okay? So, the prize question would be, if I was to lesion this nerve indicated with a little arrow right now, what would be a symptom that you would expect in the patient? Let me give you a hint. The nerve I am indicating, or trying to indicate, is the chorda tympani. I'm only lesioning the chorda tympani on one side. So, if I was to lesion the chorda tympani on one side, I would be lesioning the parasympathetic fibers, but also the special sensory fibers, aka taste fibers in this case. That means on the affected side, if this is the right side, I would not be able to produce saliva from these two glands, and I would lose the ability to taste from the anterior 2/3 of my tongue on the right side. I would, however, still feel it if I bite my tongue, because the sensory afferents, the general sensory afferents that are coming via the lingual nerve, they are still there. They are not affected. On the other hand, to decrease or to prevent tear production, I would actually have to lesion something between the pterygopalatine ganglion and the lacrimal gland, or parts of the facial nerve, like the greater petrosal nerve, prior to this. Okay, let's have a brief look at the vascular supply of the face. Okay, so if I zoom in a little bit here, here is the facial artery, right? And you might already know that the facial artery is a branch of the external carotid artery. Some people actually might call it the external maxillary artery. However, it arises from the ECA, and it passes anteriorly and superiorly over the mandible. Okay, then it'll travel upwards or superiorly along the line of the nasolabial fold in the face. It'll then end by splitting in two, or bifurcating, into a lateral nasal branch and the angular artery, which should be this one here. As the facial artery crosses over the inferior border of the mandible here, it is fairly superficial. Okay, you can use that to take the pulse at that point. Anesthesiologists, for instance, can take facial pulses when they're standing at the head end of the operating table. And the facial artery has a very, very tortuous course, as you can actually see fairly well here in this animation. And so it'll give off numerous branches to the lips. Those would be labial arteries, this inferior and superior labial arteries, but also to the nose and the chin, and so on and so forth. If you have a profusely bleeding wound in the face, well, it is likely, if this is arterial, that if you compress the facial artery against the mandible down here, that you will be able to help decrease the bleeding, because you are occluding the facial artery by pushing against the inferior border of the mandible here. Here's a different view. This is the course of the facial artery all the way coming from the ECA. The veins are usually fairly similar in their course to the arteries. If you think about the course of the facial vein, it is even more superficial than the facial artery. It is a direct continuation of the angular vein that will approximately happen at the level of the inner canthus of the inner eye. So you can see just about here where the transitions between the blue and the pink. Okay, this will receive tributaries from several regions, for instance from your infraorbital, labial, submental, and the anterior jugular veins, and then the facial vein will run inferiorly down the face and curving posterolaterally to then empty into the internal jugular vein, as you can see going along here, and there's your IJV. One interesting thing about this is the facial vein is valveless, right? You might know that in the extremities, we frequently have veins that have valves. That's important for the so-called musculovenous pump that helps return blood to the heart. It also prevents that we have like increasingly tremendous high blood pressure. However, the fact that the facial vein is valveless is actually also a problem because, well, that means blood can flow not only away from here, but if you have a clot like thrombophlebitis, for instance, like an infection in the vein that occludes the blood flow, you could actually have, well, via communications with, for instance, the ophthalmic veins, well, you could actually have a route or a potential route for the spread of infection that might go all the way into the cranial cavity. And then you would need an ambulance, as you might be hearing in the background. So now let's briefly touch on the lymphatics of the face as well. Okay, so in brief, what we can say is that except for the parotid or buccal region, there are no lymph nodes in the face itself. So lymph that is coming from your scalp, the face, and the neck will drain into something that is described as the superficial ring of lymph nodes. It's also called the pericervical collar of lymph nodes, right? So there are lymph nodes that are going to be submental, so below the chin, as you can see here. Submandibular, more lymph nodes over here. There are parotid, mastoid, and occipital lymph nodes. They're located at the junction of the head and neck. The lymphatic vessels of the face will accompany other vessels of the face. Okay, so your superficial lymphatic vessels or superficial lymphatic vessels will accompany veins, and the deeper lymphatics will be accompanying arteries. All the lymphatics of the head and neck. See if I click on these different ones, here are some parotid lymph nodes, here are some lymph nodes. This is a mandibular lymph node, for instance. All the lymphatic vessels from the head and neck will drain directly or indirectly into the deep cervical lymph nodes, which is this chain of lymph nodes along the internal jugular vein. Let me see if I can add in the IJV again for us here. Lying along here, this is where this chain of lymph nodes is. Okay, these are deep cervical lymph nodes. Okay, so lymph from these deep nodes will then pass to the jugular lymphatic trunk, which joins the thoracic duct on the left side. You should be able to see it right here. That's at the left venous angle, and on the right side it'll join the right lymphatic. Respectively, this is at the venous angles. So this is the left venous angle for the thoracic duct and the right venous angle where the right lymphatic duct enters. So let's talk about one more clinical correlation. This is called Frey syndrome or gustatory sweating. Some people might also know it under the term of auriculotemporal syndrome. And so this is something that can occur in people who've had a parotidectomy. As a side note, about 80% of the salivary gland tumors are going to be parotid tumors. Okay, so if you excise the parotid gland, well, you still have the fibers that used to innervate it, right? So you have secretomotor fibers that had been going to the parotid gland that do not have a target anymore. So these fibers are then going to search new targets, and these will be sweat glands. So someone who is eating something who will be suffering from Frey syndrome or gustatory sweating, that actually enables you better to tell what this is going to entail. Well, someone who will eat after a parotidectomy might start sweating on the side of the face. Yeah? Because now, instead of the parotid gland secreting saliva as a response to eating, we have the sweat glands being activated. So, when the patient eats, you will see beads of perspiration appearing directly on the skin over the surface of where the gland used to be. So, upon gustatory stimulation, there's localized sweating right there. Okay, and some people, it can be quite annoying. And although this condition is fairly rare, the problem could have an impact on the quality of life, for example, restricting the normal activities such as eating in public. Many methods are currently used to treat it. That'll include, for instance, topical application of anticholinergic agents and antiperspirants. Or you could do an intradermal, so injection into the skin, of Botox.